Thank you, respected chairperson. At the outset, I must like to thank Amitabh sir, Shomik sir, and Shunetradi for having me here. The first thing is that this session was originally due to taken by Dr. Lakshmi Nagendra ma'am, so she couldn't come. So ma'am has given me the responsibility to talk. So important thing, we'll talk about optimizing bone health and diabetes. So I'll try whoever present here in the conference to understand what are the bone diseases which can happen in diabetes and how we can manage it. So the bone mineral density alterations or poor bone quality of in diabetes was actually way back reported in 1948, then in 1981, and then in 1991. So the concept of low bone mineral mass in diabetes was there for last 60 to 70 years. And diabetes mellitus increases the risk of fracture. If both type 1 diabetes as well as type 2 diabetes, the relative risk of around 1.23 in type 2 diabetes or around 3.3 in type 1 diabetes. So look at one of a representative case in our institute. So a patient with a poorly controlled type 2 diabetes with a long-term history of back pain and a postmenopausal status for 10 years, and she has sustained a Colles fractures 5 years back. And she undergone a bone mineral density testing in DEXA. I think DEXA was dealt yesterday by Shomik sir. So mostly we know the basics of the DEXA. So this is a lumbar spine DEXA, and having a T-score of minus 3.8. She's a postmenopausal, so we'll see the T-score. So it's a severe osteoporosis which we can see. Now the question is, what are the contributing factors? We know she is a postmenopausal, long-term diabetes history, and having a previous history of fragility fracture. So both of them, this postmenopausal status as well as poorly controlled diabetes, are actually important for this fragility fracture and low bone mineral density. So after a fragility fracture, the risk of another fracture is around 2 times more, and that is usually in the first 6 months, but only 20% receive treatment for the secondary fracture prevention. So this is a very interesting data in Japanese Ministry of Health and Welfare and Labor, that where they put the importance of fractures in osteoporosis. So we can see that is as well as important as more than important than the heart disease or in the stroke or high blood pressure disease. So important is that the diabetes, we need to know it's a chronic disease with substantial comorbidities, and among the comorbidities, low bone mineral density or osteoporosis is important, but unfortunately takes a backseat, and we have a void of understanding how this metabolic syndrome, obesity and diabetes affect the skeleton. So just initially look at Indian data, ICMR India study from Dr. V. Mohan's team. So it having a total subjects of around 54,000, and they had seen that diabetes was associated with significant high number of fractures compared to pre-diabetes and without diabetes. And if we see in the multivariate logistic regression analysis, the risk factor for fractures, diabetes, the odds ratio was 1.3. And interestingly, in this study, what we got there, that the awareness among the type 2 diabetes, that was around 56.2%, were aware of the risk of fractures. But however, almost 3/4 of the patients had a misconception that osteoporosis first presents with bone pain and then patient goes into fractures. So now look at to the diabetes related risk factors which can lead to fragility fractures or low bone mineral density. The general risk factors is obviously prior osteoporotic fractures, more than 65 years of age, low BMI, female sex, malabsorption, glucocorticoid use, rheumatoid arthritis. These are the usual factors we come across any osteoporosis evaluation. But some diabetes specific risk factors are there. They are not very consistent, but various studies have shown. So typically lumbar spine or hip T-score, if it is minor less than 2, or frequent hypoglycemic episodes, or diabetes duration of more than 10 years, or diabetes medications, specifically insulin, thiazolidinones or sulfonylurea, poorly controlled diabetes, so HbA1c of more than 8%, and obviously microvascular complications. Now, what are the various pathogenesis of this diabetes bone disease? I'm not going into very much detail, but just will touch upon briefly. So one of my paper published, a chapter will be upcoming published in RSSDI handbook. So the abnormal bone phenotype in diabetes can be divided into 4 gross types. So there can be alteration in the bone mineral density, what we have currently consistent data that type 1 diabetes generally have a lower bone mineral density. Type 2 diabetes can have lower, can have normal, can have higher as well. But most important, there is a disruption of the bone microarchitecture. So not only bone mineral density affects the fracture, it's also the bone microarchitecture that is also affected in diabetes, and that is there in both type 1 and type 2. The diabetes is typically associated with low bone turnover stage, and last point is most important. Even with the normal BMD, they are having increased risk of fracture that is typically seen in type 2 diabetes. Now about the pathogenic mechanisms, there are some common between type 1 and type 2, and there are some specific for one of the disease. So type 1 diabetes with an insulin in deficiency, they are having a low IGF-1 and GH resistance at the site of liver. So that is a very important mechanism for poor bone mineral density. Advanced glycation end products and reactive oxygen species are there in the both type 1 and type 2. Increased Rankel activity leading to osteoclastic activation in type 1. Decreased osteoprotein activity leading to poor osteoblast generations in type 2 diabetes. Diabetic kidney disease, especially in type 1 diabetes, leads to secondary hyperparathyroidism. In type 2 diabetes, another very important mechanism is adynamic bone disease. And talking about complications, the microvascular complications, so in diabetic retinopathy, there is high VEGF and abnormal bone morphogenetic proteins that causes also poor bone mass, as well as the diabetic neuropathy, which affects alpha and beta adrenergic receptors, which are heavily expressed in osteoblast. Now, for a diabetes patients come to our clinic, our OPDs, how to evaluate for bone health, which is unfortunately less seen, or rather less considered. So very important two things we need to know: how to predict the fracture risk and how to treat that. So how to predict the fracture risk? We need to do the bone mineral density by DEXA. So what are the indications of DEXA in our Indian guidelines, ISBMR? So obviously women more than 60, men more than 65 we need to do. But postmenopausal women less than 60 and men having age of 50 to 64, if there is a concerns of osteoporosis based on the clinical risk factor profile. So clinical risk factor includes diabetes, we need to remember. And even women in the menopausal transition, not in the postmenopausal phase, if they have a specific risk factor with increased fracture risk, again diabetes is such kind of that. Patients having fragility fracture before 50 years we should do. And last but not the least, diabetes is a specific condition also have been mentioned, where we need to have an individual having a condition of diabetes, we need to assess for the osteoporosis. So among these 5 indications of osteoporosis, 3 indications actually include the indications of diabetes. So actually if it's all these indications is there and the patient is diabetic, we need to go for a DEXA assessment. Now this is a typically DEXA machine. Obviously it's not available there in every area, so there is a lack of there, but still what are the, if there is a DEXA, if we have, so how we can go ahead with that. So a simple thing, a patient come to us, the clinical risk factors are there, we need to advise DEXA sites. Commonly we advise 2 sites, lumbar spine and femoral neck. Lumbar spine we see for trabecular bone, and femoral bone is a mixture of a trabecular and a cortical bone. Distal 1/3 radius we don't do for routine patients like postmenopausal or diabetes patients, but if the patient is very obese, typically in diabetes we can see, obviously the positioning in the DEXA machine that not be possible, so we can advise for distal 1/3 of the radius. Now what are the evidences which we have that in diabetes is bone mineral density is reduced or not? I will not bombard with much of the studies, but just Indian context I would like to share. So this was one of our study. I did my DM from AIIMS Jodhpur. So we did a study in type 1 diabetes and see bone mineral density as well as trabecular bone score. I just come what is trabecular bone score. So what we found, all sites BMD were less in type 1 diabetes compared to age, sex and BMI matched controls. Another similar Indian study published by Akhila Bhandarkar ma'am recently in IGM, which shows not in all sites there is difference. So actually what we can get in type 1 diabetes from Indian context, the evidences are not very consistent. We got it definitely less, but not in case of Dr. Akhila ma'am's paper. Now talking about type 2 diabetes, the type 2 diabetes, there lies the BMD paradox. I have already told earlier that the type 2 diabetes can have normal, can have lower, can have higher BMD, but their fracture risks are high. There is no doubt about that. So there are a lot of studies, lot of meta-analysis. I have just taken the latest meta-analysis in 2024, which shows in lumbar spine and femoral neck there is lower bone mineral density compared to the healthy age and sex matched controls. But the important thing in diabetes, we would advise for a DEXA to look for the bone mineral density. But interestingly, bone mineral density doesn't tell you the complete story. Just look at this case, two separate patients, similar BMD as 0.972 and 0.969. This is an absolute value. But if we see the bone microarchitecture, the upper panel shows a well-structured trabecular bone, but the lower panel shows an altered trabecular bone. So there comes the concept of trabecular bone score, which we can say significantly the lower panel have reduced trabecular bone score. So what is trabecular bone score? So it assesses the texture of the spine using the same DEXA scans, which correlates with the bony microarchitecture, which actually correlates or which signifies the pixel gray level variation in the lumbar spine DEXA images, and it can be get in the same DEXA setting as well. The DEXA machine, the hologic machines mostly, they need to have this software. And very importantly, it's a surrogate marker for bone histomorphometry. And if the patient is found to have lower trabecular bone score, they are having thinner trabeculae, reduced trabecular lumbar, and low connectivity density. So talking about trabecular bone score study, there is one meta-analysis published from India by Shoptoshi sir and Lakshmi ma'am team. So they have included 6 studies in this meta-analysis. They have found the BMD was not significantly different between type 1 diabetes and controls, but TBS was significantly reduced in type 1 diabetes compared to the healthy controls. So that we need to remember, lower trabecular bone score independently increases the fracture risk. But again, which I have already highlighted, is the DEXA adequate in India? Actually not. Compared to the developed countries, the availability of DEXA is far lower in India, obviously because of its cost. And so to bypass DEXA, can we bypass DEXA and get a fracture risk there? So we have a FRAX tool. So FRAX tool is basically combining the various clinical risk factors. I'll come to what are the components. But the problem is that having all those components, it still underestimates the risk of type 2 diabetes. So this is an online fracture risk calculation tool. These are the various components. You can just type FRAX tool India, it will come like that. So you just need to pull all these values like previous fracture, parent fractured hip, smoker, glucocorticoid intake, rheumatoid arthritis, or any secondary osteoporosis. But the interesting thing that ultimately we will get a 10-year probability fracture of major osteoporotic and hip. But for the diabetes, it actually not calculated properly, kind of under calculate or give us a lower risk of fracture, a falsely lower risk of fracture. So there are some adjustment to the FRAX tool has been suggested. So what we can do, we can increase the age 10 years. So whatever the age of the patient, if it's a 55-year-old, we can keep it at 65. We will write there at 65. We'll tick mark the rheumatoid arthritis, and if we have the BMDs there, we can, in the T-score, we can reduce 0.5 to it. But otherwise, to make it very simple, we have a FRAX Plus. So this is a FRAX Plus. This is also available in online. So we can adjust the probability by using the FRAX Plus in the online software to have an exact fracture risk in case of diabetes. Now about the management part in diabetes. So a patient comes to us, a diabetic patient poorly controlled with a poor bone mineral density or osteoporosis. So obviously we'll talk about the anti-osteoporotic therapy, but very important, which are the drugs, anti-diabetic drugs, which can affect the bone mineral density. Very importantly, this list actually is not that simple, which I have mentioned, but at least 1 or 2 points I would like to highlight. Obviously, the thiazolidinediones, the pioglitazone, having a negative effect on the bone and increases the fracture risk, especially in the postmenopausal women. So that needs to be avoided. This is the one point which I like to highlight. Very interestingly, insulin increases the effect, it increases the bone mineral density, but simultaneously it is showing increased fracture incidence. So that is a very interesting scenario where using insulin can increase the risk of hypoglycemia and can increase the risk of frequent falls, and by in turn the fracture incidence can rise. So that is one of the things we need to remember. Most of the drugs are kind of a neutral effect on the bone mineral density and the fracture incidence. Just I think insulin and thiazolidinediones we need to remember. Now, about the various osteoporosis medications which we use in type 2 diabetes, we need to remember. So we mostly have an idea that anti-resorptives like bisphosphonates and denosumab are the commonest anti-osteoporotic therapies, and along with that anabolic therapy like teriparatide, which is a PTH analogs, which we can use. So among them, any drug which can fare better in diabetes? Actually not. So this is one of a study published in 2023 which shows both anti-resorptive and anabolic shown a similar effectiveness in increasing BMD and reducing fractures when patients with or without type 2 diabetes. Now, a very interesting thing, that can any anti-osteoporotic regimen actually decrease the incidence of diabetes or can help us to control the glycemic level? So there comes a very interesting findings published in 2023, and there were some subsequent papers as well. So they evaluated denosumab and bisphosphonate and seen the incidence of type 2 diabetes there. So there was around 4,000 patients of denosumab and compared with around 21,000 patients of oral bisphosphonate and followed for 2 years. Very interestingly, they showed the incidence rate of type 2 diabetes in denosumab was lesser, significantly lesser compared to oral bisphosphonate. So they concluded that denosumab perhaps can be associated with a reduced risk of type 2 diabetes. Why? There are some mechanisms proposed that the rank, which is a monoclonal antibody which inhibits the rank and rankel interactions, the denosumab. So they are actually a pro-inflammatory master switch. So when we inhibit this rankel, it improves the insulin resistance and also it can stimulate the beta cell proliferation. So that's a very interesting finding, not very much validated, but can be helpful when we are treating such patients with diabetes. So last, about the guidelines ADA which I have highlighted in 2025. So in patients which I have already highlighted the age group according to the ISBMR guidelines, the fracture risk need to be assessed in older adults as a part of a routine care in diabetes clinical practice. I know it's very difficult for us, but how we can do as much as possible, and we should prioritize the medications with proven safety profile for bones, and we need to be careful during choosing those drugs which have an elevated risk of fractures, and very importantly we should avoid the hypoglycemia to avoid the falls and subsequent fractures. Among the anti-osteoporotic drugs, there is not much of a difference. So we can use whatever according to the osteo-BMD levels or whatever the patient scenario. So between anti-resorptives and osteoanabolic. But obviously we need to optimize calcium and vitamin D in all such patients. So I like to end here. Thank you for your kind listening. Also like to thank Lakshmi ma'am for her inputs, because it's kind of our common presentations we have made by own. So thank you very much. Thank you.